We're not covering the entire chapter. It'll just be a few things. All right, so this is technically a review of what we did in third semester. We covered chapter 17, the small portion of chapter 17, but this time we will now include specific exemplars. So for tonight, we will cover signs and symptoms and management of transplant rejection for kidney, the liver, and the heart. I'll see if there's one for the lungs, but I think I looked previously. There's no signs and symptoms, but we'll look tonight. All right, so solid organ transplants are required for patients who lost or whose organs failed. So these are these are vital organs that we are transplanting. So most patients who are donors are usually cadavers, or in the cases of liver transplants and kidney transplants, these can be living donors because we can now transplant part of a liver. It doesn't have to be a cadaver anymore because we don't need the entire liver really. We just need a lobe. And in the case of a kidney, of course, one person can live with one kidney. All right, during the matching, how we determine whether or not there's a close enough match, because the only perfect match, of course, is that of a identical twin. So therefore, most of us don't have any identical twins, so we'll have to settle with a good enough match, a close enough match. This is done via HLA identification. So HLAs are human leukocyte antigens. These are proteins found on the surface of each of our cells. Whichever cell in our body it is, they have the same HLA. So this allows your own body to recognize as they bump into each other, specifically your cytokines and your white blood cells, as they bump into and encounter cells throughout the body, there's no problem there because they can recognize them because of these protein antigens on the cell surface. So what happens if the body encounters something foreign? First to the scenes are cytokines. There are several cytokines. We're only going to discuss these few though. Table 17-4 are select cytokines involved in organ rejection. There are many. We have antihistamines, okay? But those specifically involved in organ rejection are these specific cytokines. So we have interleukins 1, 2, 6, and tumor necrosis factor. So we'll only cover these 4 cytokines. Now, this is technically not testable. The table 17-4, there's no questions on this one. But we just need to look at them in order to understand the activity of our chosen drugs. So that you can see why those drugs are used for to prevent and manage organ rejection, because this is what they target. So we have pro-inflammatory cytokines. These are the parts of your immune system that triggers or stimulates the production of your lymphocytes, which are involved in the actual killing of organisms, okay, of foreign invaders. Okay, so these guys, yes.
You sound horrible today.
Yeah, you too.
No, you're breaking up a lot, Professor.
I can't. I mean, it's probably the internet connection, but so far, if once this happens, it's always been okay on the recording though. It's not affected. But bear with me. Just interrupt me if you have a question. Do you have any so far?
Professor, I have a suggestion, please, if you don't mind.
I can't hear you, sir.
Can you hear me now?
Yes.
I have a suggestion. So when you upload these classes, is it possible that we ask questions on the comments and on YouTube so that you can, like, if we want to ask questions, can we ask them in the comments section?
No, it's better. You have my phone number. It's better that you send me a text message. I don't. All I do in YouTube is just upload it. I never see it again after that.
Okay, thank you.
All right. Any other question? All right. So interleukins 1, 2, 6, and TNF are again the major cytokines involved in organ rejection. Look at their roles. Look at interleukin 1, for instance. This thing induces fever, stimulates prostaglandins. Prostaglandins are vasoconstrictors, and then they increase the growth of CD4 plus set T cells. You remember these guys from HIV? Next are interleukin 2. These increase the growth and differentiation of T lymphocytes, and that's just natural cell activity against cancer. So my point here is that later, when we look at the drug therapy, which are designed to these inflammatory cytokines here, we can already know what the possible side effects are because of that can result from the drug therapy. So, for instance, if let's say we have a drug, specifically as the main methylphenolate, will if you take those drugs, what would be a possible side effect because you're expressing the activity of this, which is this, what would be a natural side effect? Or anybody?
We haven't heard you since you started on this chart.
Yeah, this is the first time I just heard you say anybody. Professor, sorry.
So your connection's really bad.
Switch to a different computer, okay? I'll be right back. All right, so let's start over. So I was saying with solid organ transplants, how they match a graft and a donor, or a graft or a host, or a donor and a recipient is based on HLAs. HLAs are human leukocyte antigens or proteins found on the surface of every cell. So as your white blood cells, your immune system cells circulate and then bump into or encounter various cells in your body, as long as the HLAs match, then they recognize the cell as self. Otherwise, then it is automatically non-self, and therefore they will stimulate or activate the immune system to grow and multiply, and then find and destroy that invader. Okay. So in the case of solid organ transplants, the only way we can preserve the graft, which is the donor organ or tissue, is to suppress the immune system. However, we will not be suppressing the entire immune system because not all of them are involved in the activity specifically for organ rejection. So before we go to drug therapy, this is not testable. This is just to understand the effects of the drugs. So we have pro-inflammatory cytokines, particularly interleukins 1, 2, 6, and TNF, or tumor necrosis factor. If you look at each activity, interleukin 1, for instance, these are what they do. And interleukin 2, look at the activity here. They are enhance the activity of natural killer cells against cancer cells. And then interleukin 6, they here fibrinogen and protein C are important in order to cause the or prevent the clotting. So these will be significant later when we get to DIC, which later in the semester. And this one will be increasing the numbers of sensitized B lymphocytes. B lymphocytes are the parts of your immune system that are involved in intelligence. Okay, so if we compare it to the military, the actual soldiers are your T lymphocytes, whereas your B lymphocytes are the ones that collect intelligence. Okay, so they mark the target to make them easier for the T lymphocytes or the natural killer cells for them to target the enemy. Then we have tumor necrosis factors. These are responsible for the symptoms you see in rheumatoid arthritis, in lupus, for instance, or most other autoimmune disorders, or like systemic sclerosis, for instance. Now, here are the 3 types of transplant rejections. So again, the presence of the graft inside a host, because they have different HLAs, they're not an exact match. The only exact match is that of a identical twin. And since most of us don't have identical twins, so if we are ever matched with another donor, then because the HLAs are not exactly alike, so all we can do to preserve the organ or the tissue that was transplanted is to suppress the immune system, to suppress the activity of these cytokines right here, because these cytokines are the ones that trigger the T lymphocytes. So per se, we are not going to target your T lymphocytes because they have nothing to do with the orders. Okay, T lymphocytes are just following orders. Okay, that's their job to do. So therefore, all you can do is suppress the very cytokines that cause them to be activated. Are you with me so far?
Yes.
Okay. So now we go to, before we go to management, let's look at 3 types of rejection first. The rarest of all and the fastest in onset is called hyperacute rejection. So there are 3 things we need to answer here. One is, for each type, we will ask, when does it occur? Why does it occur? What is the exact mechanism? And then what do we do about it? Okay. We'll look at the signs and symptoms later. We'll go to chapters 68 for kidney, 58 for the liver, and then third, we'll go to chapter 35 for the heart. All right, so we will leave 17 shortly. So in hyperacute rejection, first question is, when does it occur? This occurs within the first 24 to 48 hours of the transplant. This is very rare because if you think about it, the doctors made sure that the transplant will go, without any incident, especially with hyperacute rejection, because for several months, we tried to suppress not only the donor but also especially the recipient. Okay, so we suppress both patients, the donor and the recipient, to make sure we don't have any rejection. Okay, there will be enough immunosuppression to stop the host from attacking the graft. And we did a meticulous process of matching it, that it's close enough. And now comes the day that we did the transplant procedure, and we don't expect this thing from happening. However, this is just a unfortunate event that there are some pre-existing antibodies left in the donor organ. So when this happens, though, again, this is very rare. This is just an unfortunate event, if it ever happens, that once the blood starts flowing into the graft, because what they do is, of course, they clamp the vessels. So they anastomose the vessels, they connect the vessels of the host to the vessels into the organ being transplanted, and then they remove the clamps, and then blood starts flowing through the organ. When that happens, because of these pre-existing antibodies to the antigens between the graft and the host, this triggers an antigen antibody complex, which triggers clots, and we're talking about widespread clots here. So this occurs within a few minutes as soon as blood flows to the graft. We call the graft the transplanted organ, okay, and then the patient receiving it as the host. So as blood flows through the graft here, it causes this antigen antibody reaction, causing formation of blood clots all over. Now these are the clots are so widespread that they cause occlusion. So they will occlude the organ, therefore there's no more blood flow. It results in ischemia, and the graft becomes necrotic. So this can occur right there during the surgery, as soon as the clamps are removed and then blood flows to it, or it can also occur within the next few hours after the patient was out of surgery. So again, this occurs between the first 24 to first 48 hours of surgery. Next question is, what can we do about it? Nothing really, because the organ is already necrotic because of the tissue ischemia. The graft is dead. So all we can do is take it back out, and then the patient is back to square one. Okay, so we'll find another donor, and hopefully we do it right this time, and this will will not happen again. But that's easier said, though. It was hard to get the match in the first place, and then this happened, so just a very unlucky situation. Question on hyperacute rejection?
No.
Okay, next is acute rejection. This is the most common type. When does it occur? All right, so it occurs 1 to 3 months after the transplantation, and then sporadically, meaning there won't be one episode of acute rejection. There will be several. As long as the graft stays in the host, there will be a chance of repeated episodes of acute rejection. Now, what happens? Okay, there are two mechanisms involved here. One is vasculitis, which different, not necrosis. Here in hyperacute rejection, you had widespread clotting. There's no widespread clotting here. So it's the vessel is what dies, not there's no clots that cause the organ to die. It's really the vessels inside the graft. But that's not the only thing wrong though. The second mechanism is really what will cause the death of the graft. It's really the cytotoxic and cytolytic activity of the T cells. So what happens is, even though we gave this patient, we gave the host immunosuppressants, the body somehow found a way to still produce and stimulate the immune system. So they still manage to, attack the graft, and then they penetrate the organ and then start killing it. What can we do about it? Because it's cytotoxic in nature, meaning this is related to your immune system activity. So all we can do, the doctor will either add more drugs or increase the dose of the immunosuppressants. So here's your answer. Drug management may limit the damage to the organ, and we can still preserve the graft. Okay. But again, this will occur several times though. So throughout the patient's lifetime, so this will occur again and again. And each time it occurs, all we can do is just adjust the medications again, put the patient on high doses of steroids, for instance, and then hopefully that will save the organ, and then we move on. Any question on acute rejection? All right, lastly, it is chronic rejection. So this one, by the word itself, chronic, so when does it happen? This occurs several years or several months later. However, the changes here are so subtle. It is related to chronic inflammation and scarring. So what happens is there is inflammation, and whenever there's inflammation around, there's edema, and then there is swelling, right? In and around the organ. So that causes some of the organs to, here, this is the exact mechanism. So the smooth muscles of the artery overgrow and occlude the vessels. But this doesn't occur widespread though. So this is little by little. So section by section, this happens. So some arteries overgrow, and then occlusion occurs. A part of it dies, a part of it becomes scar tissue. And then another section of the graft does the same until before we know it, several years later, most of the graft is now scar tissue instead of functional tissue. So what can we do about it? We can't stop the process, although we can delay it. We can delay using drug therapy. So same thing, we can adjust the doses, or maybe add more drugs. But really the outcome will be the same. The only thing we can do again is to delay the progression. However, the patient will eventually lose that organ, and we will be back to status quo. So it comes back again to how we started in the first place. Any question on chronic rejection?
So it's just a matter of, so the professor, it's just a matter of having the patient outlive the like the life of the organ. That's why a lot of people don't have to.
Basically, that's what we're trying to do. So again, it's like the end result here is, it's like the patient's organ, the graft that we gave them, failed all over again. So it's like in the first place, their original organ, let's say their original kidney failed, right? For whatever reason, diabetes, lupus, for instance, they suffered kidney damage, hypertension, and then they got lucky and they got a transplant. However, they suffered chronic rejection. So several years later, that graft that they received failed again because it became more scar tissue than functional tissue now. So they lost another organ. So they're back again to how they started.
Thank
Was
you.
that your question?
Yes, sir.
Okay. All right, management. So these are the doctor's choices. We will only discuss three. First are corticosteroids. By the definition here of their action, they broadly inhibit cytokine production. So it's not cell specific. So it could be any or all of these cytokines right here. So steroids are not cell specific. So they broadly inhibit. They could be inhibiting all of these, all four of these. So therefore, this will be going faster because the side effects we already discussed under adrenal disorders. So a patient who either has Addison's disease or received adrenalectomy, bilateral adrenalectomy for Cushing's disease, now is taking steroids. So long term, because they have to take these for a long time, these are your side effects. The next group are more cell specific. So here for steroids, they're not routinely given. These are more used for during rejection episodes. So let's say the patient undergoes acute or chronic rejection, then steroids will be given because they're not, as you can see, they're not good for long-term use because patient will have Cushing's syndrome, and then you have other problems that can arise from that therapy. So the day-to-day maintenance medications are calcineurin inhibitors and anti-proliferatives. So it's a combination of these and these guys right here. So let's begin with calcineurin inhibitors. This group of drugs only inhibit interleukin-2. So specifically targets interleukin-2, whose job is what again? Interleukin-2 is responsible for the growth and differentiation of T lymphocytes and enhancing natural killer cell activity against cancer. So that's why it would only make sense that look at one of the side effects of calcineurin inhibitors. It will cause malignancies. Malignancies also for this one. Okay, so cyclosporin and tacrolimus are the two commonly used calcineurin inhibitors. So that's one of their common side effects, as well as, of course, both will cause opportunistic infection because they will suppress the immune system. And please look at the other side effects on your own. Like this one is known for gingival hyperplasia. This will not be the last time you see these drugs, by the way, and I'm sure you've seen them also in previous semesters, specifically last semester. If you remember them during autoimmune disorders when you talk about lupus or multiple sclerosis, these are the same drugs used, correct? Next group are anti-proliferatives. By the term itself, these are cancer or anti-cancer medications. So their main activity is to inhibit something essential to DNA synthesis, so therefore they suppress cell division. So they will affect division of specifically lymphocytes. However, because the drug won't distinguish between lymphocytes and other blood cells, which are also rapidly dividing. So as a result, though, these drugs, specifically azathioprine, mycophenolate, are going to cause pancytopenia. So all of them cause bone marrow suppression, and once myelosuppression occurs, then you have anemia, thrombocytopenia, and neutropenia. And just like your calcineurin inhibitors, they also cause malignancies. Okay, because our immune system cells do fight cancer cells. They can recognize specifically malignant tumor cells because they have a different HLA now, unlike benign cells which resemble normal cells. So your immune system actually are actively killing mutated cells within your body. Any questions on the management? Okay, let's go now to each exemplar. Let's do the kidneys first. Signs and symptoms of acute chronic Hyperacute, acute, and chronic rejection is in table 6813, page 1423. So this is the perfect example of chapter 17. So look at hyperacute rejection within 48 hours. So anywhere between first 24 to 48 hours, acute rejection, 1 week to any time. And then this one is several months to several years. These are your signs and symptoms. For hyperacute, because we have no time, as you can see, we don't see these because these occur so fast that the patient won't have enough time to develop these or these, okay, because they occur so suddenly. So the only manifestation here is increased temperature and increased blood pressure, and of course pain at the transplant site because the organ is dead. So the tissue necrosis there, of course, there's dead tissue, so of course there will be pain. There's ischemia, basically. Ischemia led to necrosis, and then it's a dead organ. So the symptoms occur so fast that you don't get a chance to develop increased BUN creatinine. Of course, there may be, but there's really no time. They happen just so quickly. And as we already mentioned, is there treatment for hyperacute? Nothing. You just take it out and put it on the grill, whatever you want to do. It's your kidney. You paid for it. The acute rejection, there are observable signs and symptoms now. So because the patient's organ is being attacked, the graft is being attacked, so this is like, it resembles acute kidney injury because the onset is quicker. I mean, not as quick as hyperacute, but the damage to the organ here happens within a few days. So therefore, you will see signs and symptoms of acute kidney injury, particularly the oliguric phase of AKI. Okay, so if you remember earlier in this chapter, when our last semester, you talked about AKI during the oliguric phase. These are the signs and symptoms. And as chapter 17 said, the management is we increase the dose of your immunosuppressive agents. And finally, chronic. The key here between the two is the development. This one is gradual, whereas this one, you'll see it spike almost overnight, okay, because it can occur over several hours only. This is so subtle that it occurs over several months to several years. So the increase here is gradual. But over time, of course, you will see that. So if you compare both, this would be AKI and this one would be CKD. Does that help? Because that's how they develop. AKI, so sudden, and then CKD over months or years. And as we already mentioned in chapter 17, management would be still the same here. You increase the dosage of your immunosuppressive agents until it's gone, and then you go back to dialysis. Questions on kidney rejection?
No.
All right, let's go to liver. Then we'll end with the lungs. Okay, your first signs and symptoms are here. It's an action alert on page
Yes.
11,
I want to ask you what page?
1188. So those are your signs and symptoms. Now, I didn't see any chronic rejection here. I only see acute rejection. So I guess chronic rejection is not common in liver transplants because I don't see it anywhere here. Now, the treatment, of course, is already mentioned in chapter 17. So as far as, let me just make sure, it's right here. Table, this action alert, and also there's a table here for acute graft rejection. So I don't see any chronic rejection, right? So these are your signs and symptoms, along with what mentioned in the action alert a few paragraphs up, and we already know this from chapter 17. Any question on liver? You're a very nice audience. Okay, let's go to heart, and that will be it.
I have a question. So you want us to go over that entire chart, correct?
The which one again? The table, right? No, only the transplant part.
At the table, yes. Only the,
Only the acute rejection.
okay, yes.
Yeah, that was, yeah, because that's all our topic is on. We're not discussing chapter 58 all over again. You
Okay.
finished that last semester, right?
Yeah.
Okay. Okay, for heart, this should be under cardiomyopathy because those are the patients that require transplants. Okay, so similar to chapter 58, there's a critical rescue here. Signs and symptoms, but it refers you back to 3510, so never mind. 3510, if you notice, it's not really specific to rejection. It's their signs and symptoms of what? Heart failure. Yeah?
Yes.
Okay, so the same pattern as what you saw in chapter 68 for acute rejection and chronic rejection. So the symptoms there were consistent with, for acute rejection, symptoms of AKI, particularly the oliguric phase of AKI. And then in the case of chronic rejection, you saw signs and symptoms of CKD there, chronic kidney disease. And in liver, you saw the symptoms, the right upper quad pain, the jaundice, the elevated ALT, AST. So it's like symptoms of liver failure, correct? And then same thing here in chapter 35, the signs and symptoms are symptoms of heart failure. And plus this one, of course, because the patients, once the heart failure is chronic, then that means there will be an extended period of congestion in the atria, leading to the development of atrial fibrillation. And that's it. Any questions on organ rejection?